for me, I'm very much, I'm here's a problem. Let's take care of it. I have a solution for that.
Our goal when we opened was to provide the highest quality care that was possible at a price people could afford.
I literally talk to physicians daily. Kelly, I can't even log in to see my own billing. I have no idea what's going on. I get a report once a month and nobody can explain it to me. I make it a point to train the physicians how to go and pull their own report.
I'm going to be on the course reporting tomorrow afternoon.
You are?
I am. I'm going to follow Jordan Spieth and Will Zalatoris and Scotty Scheffler. I'm not really reporting, but I am going to go watch the play.
Probably drink a couple beers.
Yeah, I might have a beer or two tomorrow afternoon. I mean, that would make my commentary even better.
Well, welcome everybody to our next episode of the Cutting Edge Podcast. I believe this is episode 12? Episode 13, I think, actually. Lucky number 13. And actually is episode number 14. Now that I reflect, time flies, Tyler.
Yeah, CJ, you're struggling a little bit here in this intro.
Just trying to re-enter society after being sick.
Yes.
And being quarantined.
We're glad you're better.
Got to try to put my thoughts back together. So, before we get started, let's give a few mentions to folks that have supported us. So, first mention is for Texas Assist Surgical Assist Staffing, one of our sponsors, the Carrington Group. Is that correct?
Yeah, that's right.
The Carrington Group, which Tyler happens to be your firm, well supported by Jen Eaton and Moonshot Marketing Group. Jen, shout out to you for helping us with social media and web presence. And Ortho Lone Star also has been a ardent supporter of ours. So thanks to Ortho Lone Star. I think we're going to have a few more folks join us in support, which is going to be great because we've got great content and just want to be able to share it with as many folks as possible. So you can also find us, ways to find us. You can find us on Instagram. You can find us on LinkedIn. You can find us on our YouTube channel, The Cutting Edge Podcast. Also find us on Facebook. Basically, if it's a primary social media channel, you can find us. We don't TikTok. We don't do some of that young hip stuff.
Yeah.
But, if you really wanted to, we probably could.
Listen, I was struggling finding the podcast on Apple Podcasts, and I had to give it to my wife the other day on the road, and she informed me that I didn't write the Cutting Edge Podcast, and that's the reason why I couldn't find it. So,
well, which brings up,
we don't TikTok. That's a fact.
Well, so you can find us on Spotify and Apple Podcasts as well. So we have channels there with all of our prior content, some great stuff that's been up there, and man, a great topic, something that I'm passionate about because I've worked in orthopedics now for nearly 8 years. But the topic today is it's hip to be healed.
Ooh. Are we talking about hips?
We're talking about hips.
All right.
And great guest with us today, Dr. Richard Evanson, who is with Plano Orthopedics and Sports Medicine. Dr. Evanson, thanks for joining us today, man.
Yeah, you're welcome. Appreciate you guys having me today.
Absolutely. And then obviously co-host and representing the average Joe, Mr. Tyler Tallman.
Yes.
So very curious what you think on some of the things we're going to talk, because I'm sure Dr. Evanson and I are going to talk a lot of shop, and you're going to hear some terms and some phrases that you're like, well, what is that? What is that? So
I personally think this is going to be an all-star appearance for me today because I'm feeling very below average. So yeah, so I think I'm going to meet that title well.
Well, we might as well jump right in because
Yeah.
we got lots of ground to cover. So, Dr. Evanson, we're going to start with you and just help us with a little bit of background information on you. Where'd you grow up? How'd you get into medicine? Kind of what's been your journey here to Dallas?
I grew up in Colorado.
Okay.
And was heavily involved in sports, and then I ended up going to Brigham Young University for undergrad, where I met my wife, and then I always kind of knew I wanted to do medicine even from high school, and everybody told me that'll change. You'll change your decision 100 times, but I kind of kept with it and just always felt a desire to be involved in medicine and athletics to some degree. I went on after undergrad to get my my degree at A.T. Still University, Missouri, and then I did my residency training in orthopedics in the military through the Army at Eisenhower Army Medical Center. It's in Augusta,
Really?
Georgia.
Yeah.
I spent 5 good years there, and very, very long, painful 5 years there. But then I ended up doing 4 years of payback as a general orthopedist to the Army at Fort Benning in Columbus, Georgia, where the Special Forces train and the Airborne Rangers train. And,
Very cool.
and it was during that time where I developed a passion for hips. There was 7 other surgeons, and I enjoyed doing hips, so I kind of became the self-designated hip surgeon, and did more and more hip surgery, and just developed a passion for it. And then had to make plans as I got out of the Army and what I was going to do next. And I learned about a hip fellowship at Duke University. Applied, was accepted, and went to Duke University for a year and did a year fellowship in hip surgery, and that involves all spectrums of the hip, from hip preservation to from younger patients to older patients, all the way up to joint replacements and the whole spectrum of hip care. So
I mean, how much, you say fellowship was 1 year, right?
yeah.
So how much additional information did you really learn in that year? Like, is it like going from, elementary school to college, or, is it just the natural progression of another year of education?
It was a natural progression of education. It was adding a whole nother year, but where we were specifically focusing on just the hip. And it was like drinking from a fire hose. I mean, it was a lot of information fast, and it was a fantastic year, probably my favorite year of all my training.
Because it was your last?
Yeah.
I mean,
that's
I have to tell you, his level of tenacity, I already know it's a way above average to be able to live in Augusta, Georgia for 5 years. I mean, outside of the golf course, there's not much going on in Augusta, right?
It's actually, Augusta's a great place. We really enjoy living there, and if we had the opportunity to end up there, that wouldn't have been so bad. We just didn't have any family out in that area, but we loved Augusta, and loved going to the Masters and seeing all the people that came for that. But Georgia was a good home for 9 years, 5 years in Augusta and 4 in Fort Benning, and it was a good time. But
so having spent 9 years in the military, and training, what do you think your greatest benefit turned out to be, being able to train in that environment versus a traditional academic environment?
Great question. There's a lot of benefits to having trained in the military. There's a diverse background in both your surgical skills and the amount of trauma and various wounds that you see and treat. The education I received through the military was phenomenal, and I'd put it up against any education in the country. It was by far one of the best decisions that I had made to train through the military, and orthopedics in particular. Probably the best benefit of doing the military route was treating soldiers. And
I mean, where you were, you had special forces guys. So it's not like just your average. I mean, I'm sure you saw some average infantry, right? But to be able to work with guys that are just elite, really, they're elite athletes.
Yeah, especially the Rangers in particular. Most of the special forces are over at in North Carolina, but the Rangers and the Ranger School and the airborne schools are all there at Fort Benning. So I got to work with them quite a bit, and that was a great experience, just working with them, helping them get back to battle and getting back to the training that they had to do every day. It was a very different lifestyle and very intense lifestyle, and it was fun working with them. It was like I'd compare that to working with a professional sports team, where you have high-level athletes that have to get back in the game, that don't have an option to just sit and rest, and their life and their salary depends on it. So it was a great opportunity. It was a great experience.
That's awesome. So, I mean, what brought you to Dallas other than the job? Was there some other attractant to want to be in North Texas for you or your wife?
Friends and family is what brought us to Dallas. So my wife is from Houston, but she loves Texas. She loves the warm weather. And it was the group with Plain Orthopedics that really drew me to Dallas. I was looking at several different cities, had several different offers, and this particular offer with this group was just exactly what I was looking for. They were looking for a hip specialist and someone, they didn't have a hip specialist in this area, and I really enjoyed the partners, I enjoyed the group, everything that they stood for, their history, and so it was just a perfect fit. And then visiting Dallas, we loved Dallas and had some friends and family in the area, so it just worked out great.
That's awesome, man. Well, we're glad you're here, because obviously there's, 7.5 million people that live in DFW now and growing. I think it's projected to double in the next 12 or 13 years. It's a crazy
It's amazing.
number.
I don't know where we're going to put them all.
Yeah, right. I mean,
Further north, right?
yeah. Just gonna at some point you're gonna have
When
to build
Texas
up.
and Oklahoma grew together, that's a reality. So
Certainly could happen. Well, when we're talking orthopedics, and now we're talking hips specifically, I think every one of us at this table has had hip pain, right? I don't know. I know anybody who's never had hip pain, but hip pain, severe hip pain, is really a bear. And I think for our audience, we get a combination of physicians and lay people that listen to our podcast. Maybe talk through when somebody is having hip pain. At what point would you encourage somebody to go in and have an evaluation, and then start talking about treatment options? I think that's a great place for us to kick off.
So there's lots of different treatment options and a whole spectrum of hip pathology or hip injuries. And the perspective I obtained at Duke University was a variety of treatment options. To answer your question initially, patients who have continued hip pain that is not resolving or is debilitating and keeping them from doing the activities that they want to do is a good enough reason to come and see someone to make sure there's not something major or serious going on. Quick evaluation could mean that you just need some physical therapy or perhaps an injection, or it may be something more serious like a fracture or necrosis of the head, of the femur, or something that requires surgery. Could be something more serious. So there's a whole spectrum of injuries as well as treatment options, but until you get evaluated, you may not know exactly what that is.
So how often does physical therapy resolve? If you look at your patient population that you see, how often does physical therapy or the most conservative treatment resolve the issue?
I would say a large majority of the time. Conservative care with physical therapy, anti-inflammatories, and the right type of physical therapy makes a huge difference and can resolve probably the majority of injuries.
So when you say the right kind of physical therapy, what do you mean?
When you go to a physical therapist, there are types of activities that can make things worse, and you may not realize that they are actually making things worse. So if you're not with a trained professional, oftentimes I get a patient who says, well, I'll just go to the gym on my own. And they don't realize that there's a reason why these physical therapists are trained the way they are, because they know what activities you need to avoid and which muscle groups you need to work in order to get the maximum benefit out of therapy. So it's not just a routine to just send someone to physical therapy. We're sending you to physical therapy because we know that it's been proven to be very effective and will likely resolve your issue if it's done correctly. So by going to a trained specialist, someone who knows what they're doing, whether that be a particular type of physical therapy or a certain location or a certain specialist, those are the details that we're aware of. And so by coming to us and getting evaluated, we can send you point you in the right direction.
How often do those do it yourselfers end up back in your office with a worse injury than they did before?
Almost all the time.
Yeah.
All the time. Yep.
Yeah.
More often than not, I get them back in my office, I send them to a physical therapist, and then they just wish, hey man, I wish I had just done this in the first place. Yeah. So,
or maybe it's not that they're trying to do physical therapy themselves. Maybe they don't do anything, and then they go back out with their regular daily life for the activity and keep straining it and cause a bigger injury.
Yeah.
Yeah. I mean, how often does rest, just lay off what you're doing, help fix hip issues. I mean, is that a common way to get the resolution that the patient's looking for? Or
I would say it can. Oftentimes, resting for a couple weeks or just taking some anti-inflammatories and maybe modifying your activities can help. I'd say more often than not, it's going to require more than just rest. So
Interesting. So, you mentioned hip injections
mm-hmm.
as a treatment option.
Yeah.
So talk to us, when I think of an injection, I think of a needle that big and about that big around.
Yeah.
The old Nurse Ratchet, going to stick you in the behind. But
Thanks. Thanks for the visual.
You like that visual?
Yeah, that was good.
So, and when you're talking about a hip injection, maybe talk us through what's the details around that?
So the traditional way of doing a hip injection is sending you to a surgery center or a hospital. And the newer way of doing it is a ultrasound guided injection in the clinic.
Really?
So there's 4 good reasons why you should avoid getting a hip injection in a surgery center or a hospital. And I myself am guilty of having done the same thing. I used to send patients to a surgery center or a hospital, let a radiologist do the injection under x-ray, and then the patients would come back and you try to get those results. It wasn't until my fellowship at Duke that I realized there's a much better way of doing it, and that is in your own clinic under ultrasound. The 4 main reasons why this is so much better is, 1, it's a huge inconvenience to go to a surgery center or a hospital. You got to schedule it, take out an entire day of your time, have a driver with you, and a lot of people don't have that amount of time to do a quick injection in the hip. Mm-hmm. The other reason why it's better to do it in the clinic is cost. Mm-hmm. Okay, you go to a surgery center or a hospital, and I know I'm not going to be very popular by saying a lot of these things, but The reality is, you go to a surgery center or hospital, that will charge your insurance anywhere between $4,000 to $6,000 for hip injection. You do an injection in the clinic, it costs $140.
Oh my gosh!
Wait a minute, hold on.
Yes.
$4,000 to $6,000
Yes.
versus $140 or $50 or $60
in the clinic. Yeah. So there's multiple reasons or motivations why to do one way or the other, and my personal view is that it's not only better for the patient, better for insurance, but it's overall better for our healthcare system to do something as simple and easy as that in the clinic. So now you're wondering, okay, why doesn't everybody just do it in the clinic, right? Well, the difficulty with doing a hip injection is the depth, as you were mentioning, the length of the needle. Well, it is a long needle, and that can be intimidating to some patients. However, we've been doing injections in the shoulder and the knee for decades right there in the clinic, and it's really no different. The biggest difference is knowing the location. Because it's so deep, it's hard to make sure you're in the right spot. And so in order to make sure you're in the right spot, you have to have an x-ray or an ultrasound. Not everyone's trained in ultrasound. I never received any ultrasound training in my orthopedic residency. It wasn't until my Duke fellowship that I actually received specific training on how to use an ultrasound. And that's a skill that takes some time to learn and become efficient at. So in the clinic, I can use an ultrasound versus having to use radiation on a patient in a surgery center and use an x-ray in order to get it in, make sure I'm in the right spot. So there's a third reason why people should not have their injections at a surgery center or a hospital. Just come to the clinic. We can do it in literally 5 to 10 minutes.
You do it right in the patient room, or do you have a procedure room, or?
Don't even need a procedure room. We just do it right there in the clinic in our regular room. Bring an ultrasound machine in. We lay the patient down, numb up the site. It literally takes about 2 minutes. Hurts no more than getting a vaccine. and it's pretty quick and easy. So the radiation is another reason why you should avoid that. So there's several reasons why this is a newer, more advanced method of treating hip pain. And the other reason, I mentioned there's 4 reasons, and I got caught up on the radiation. But the 4th reason is because you can use an injection for both therapeutic and diagnostic purposes. What I mean by that is hip pain can come from lots of different sources. It can come from the back. It can come from female organs. It can come from the tendons. It may just be tendonitis. It may not be in the actual ball and socket joint. So that is sometimes hard to diagnose. And that's what I actually enjoy about the hip, is the fact that it's challenging. It's hard to really know, is the source of your pain coming from your back or your hip or something else? And the best way to do that, more sensitive, more specific than an MRI or a physical exam or the history from the patient, is a diagnostic injection in the hip. So let me explain that, because this is important to understand. The hip joint, the ball and socket joint, is surrounded by a capsule. Think of it like a balloon that's like watertight, holds joint fluid inside, okay? Separates it from the rest of the hip muscles and everything else around the hip, okay? So that watertight balloon, okay, surrounds the actual joint, the cartilage, the labrum, etc., everything that's inside the actual joint. If we're unsure of whether or not the pain is coming from the hip or the back, all you have to do is a quick injection into the hip joint with an anesthetic. You put numbing medicine in the hip joint, and immediately they will either get relief or not get relief. So it's diagnostic. So if I put numbing medicine in your hip joint and I move your hip around, you're like, wow, my pain is completely gone, or it's numb. Well, that's the purpose. And I can 100% say, I know your problem is in your hip joint. On the contrary, if I inject your hip joint and you're like, yeah, I feel no different, I can safely say, well, it's probably coming from your back or something else outside the hip joint. So there's a huge benefit. If I send someone to a hospital or surgery center, to a radiologist, and I see them a few weeks later, you can ask them, okay, so how'd the hip injection go? Did you get any relief with the numbing medicine? And you know what they'll say? No. You're like, well, I don't know. I went home and laid down. And then a couple hours later, the numbing medicines wore off, and there's no diagnostic benefit to the whole injection. So you just wasted a huge benefit actually doing an injection. Whereas in a clinic, I can immediately get an answer and response, and I know your problem is in the hip, or it's not. So that's 4 big reasons, and why
it's
put a lot
so
of emphasis on
is the
this.
reason I got to go back to cost for just a second.
Yeah.
I'm assuming that the cost is incredibly high because now they're having to rent out an entire operating room basically to do this. A procedure that doesn't need an operating room, and there's, I guess, expense with that. Well, where's the rest of the expense coming to make this a $6,000 moment?
Good. So the OR, operating rooms, are very expensive to run, okay? But the equipment, okay, to do an x-ray, you got to have a radiology tech come in and push the button on the x-ray machine. You've got to have an anesthesiologist, anesthesia to put you to sleep,
There's
which,
2,000.
might I add, has risks in and of itself. Is far more risky to go to a surgery center or hospital and go under anesthesia for a quick injection that could be done in the clinic in 5 minutes under ultrasound.
So but I guess that's the part that's frightening to me is why would we ever recommend somebody go under anesthesia, even if it's local,
so
for a hip injection that we can do in 10 minutes inside of a clinic?
Well, that's because not everybody knows how to do it in a clinic. That's a simple answer. Is a lot of people aren't trained. They're not aware. This is a newer procedure. This is a newer way of doing it. A lot of people don't know how to use an ultrasound. The other downfall is that when you do an injection in clinic, in the time that I do an injection, you could see 3 or 4 more patients. So it's hard to maximize your efficiency when you're breaking up your schedule and doing injections, you got to get the equipment, you got to bring the ultrasound in, you got to re-examine.
So
the
it just
patient.
comes back
So
to money at the end of the day.
it comes back to efficiency and the ability to do the test. So I imagine as more surgeons adapt to doing injections under ultrasound, that'll be something that
you've made some fans today, and you've made some enemies.
Yeah.
And I'm not quite
Yeah.
sure what bucket they all come from, but I know
Yeah.
for sure you made fans of some of these big self-funded employers who might hear this,
Yeah.
and they're going, well, we should have a specific benefit that just covers that 100% if it's done in the clinic. But the other thing that I consider here is everybody a candidate to have it done under ultrasound in the clinic? Or are there candidates that you do want to take them to the surgery center for their injection?
So morbidly obese patients are obviously a lot harder to do an injection for. You would need an extra long needle. Their pannus can sometimes get in the way when you're doing an injection in the hip. You're doing it through the front, okay? So obviously if they're a larger person, that's a lot harder to do, and those particular patients may require to go to a hospital or surgery center. But I would say 90% of patients we are able to do, at least 90% of patients we're able to do right there in the clinic.
Interesting, isn't it? I mean, there's so much. We've had a urologist that's just a leading guy in his space from UT Southwestern on. Right, we've had folks in some other specialties too in surgical robotics. It's amazing the gap between what some guys are doing. It feels like the Grand Canyon, even though you guys essentially all have the same basic training. The post-residency, post-fellowship investment in training seems to really be a huge difference. Would you agree with that statement?
And from my seat, the way I see it as the average Joe in the room is, wow, I always knew you had options for treatment, but I didn't realize how many options I have. And it's not just about the actual medical treatment. I mean, here I just found out a way to save $5,900 if I ever need a hip injection.
Yeah.
I mean, the other day, but without you coming on and being candidly honest, we're going to trust the person that we walk into the room that is wearing the white coat. They're going to say, this is what you need to do. Right. And unless I go on Google and search, do I really need to spend $6,000 on a hip injection? How would we ever know? And so that's the part of it that's been interesting to me is there are a lot of choices. And I don't know if the average person out there knows how to get all of the information to make an educated decision.
I think the key part there is the average patient doesn't know what questions to ask.
Yeah.
Right. I mean, I've watched it with my parents. I've watched it with my in-laws. I mean, for those of us in the medical community, we're blessed.
Yeah.
Because we know to ask questions and to nudge and to push. And eventually we'll get to that decision tree with the physician that says we should do X, Y, or Z. But that's just not the average person. They look to you and because we had another orthopedic surgeon on, a few episodes back, and he basically said the patient wanted him to tell them what they should do. And his philosophy was, it's not my job to tell you what you should do. My job is to give you information so you can make an informed decision about your care.
Yep,
and patients would get mad at him because he's the doctor. You're supposed to tell me what to do.
Yeah.
But I think that's
generational. Well, and his perspective was that there actually might be 2 to 3 different approaches to this that can still give you to a positive result. That can give you the result you're looking for, but ultimately it comes down to you and what you're comfortable with.
Yeah, not everybody's the same.
Yeah,
right.
Every patient's different. For some, surgery may be the best option. For others, non-surgical treatment may be the best option.
Right. So let's pivot for a moment and let's talk. Soft tissue conditions or injuries versus musculoskeletal, because that's kind of the break that I see. And correct me if I'm wrong, right? If you see things through a different lens, but you were talking before we got started about labral tears, right, and about hip arthroscopy, and that seems to be more relative to soft tissue targeted conditions. Maybe help us unpack that a little bit, right? So when you're going in and you're running your diagnostics, what's your decision tree look like? And talk about how you end up at a point where you're like, hey, this patient's a candidate for hip arthroscopy.
Okay. Well, I may have a different perspective on this. So I'll admit that. But my perspective is that you should try and preserve the hip, the natural hip, as long as you can.
So to cut is to cure is not your, you don't have a sign above your door in your office that says to cut is to cure.
No. But I think having a different perspective through a hip fellowship allows me to see both sides of the spectrum and to see all the different potential treatment options. The traditional training is you're either a sports guy, sports surgeon, you do the arthroscopy, the minimally invasive stuff, or you're a joint trained surgeon. So the uniqueness about the training that I received at Duke was that I see and receive training in all aspects of hip treatments and hip surgery. So from hip preservation in young patients to older patients. And that provides a unique perspective because I'm not just a hammer seeing a nail. I'm able to see which patients are good candidates for preserving their natural hip and at what point do they require a hip replacement. Oftentimes, patients will go to a sports surgeon and they'll say, oh, I can't help you, you need a hip replacement, let me go send you to the joint replacement guy. Or vice versa, the joint replacement guy says, your hip's not bad enough, you don't need a joint replacement, I'm gonna go send you to my sports guy. And then you're seeing two different guys, two very different perspectives. And surprisingly enough, you may have that patient go to the sports guy and be like, no, you need a joint replacement. And the joint replacement guy says, well,
no.
But the joint replacement guy said, no, I don't need a joint replacement. So, you're stuck in the middle. What am I supposed to do? And that's because you're seeing things from two different lenses. So if you're able to see it through a single lens and you see the whole spectrum of treatment options, it's a much better situation for the patient. And I think you can provide better care for the patient. I know I kind of went off a little tangent from your question, but I think that's important to understand
for sure
where I'm coming from. Because I think I'm coming from the perspective that we need to start with non-surgical care first and exhaust that. If that fails, then surgery is the next option. Mm-hmm. Among those surgical options, we need to try hip preservation or knee preservation, or whatever it may be, to try and preserve your natural knee through minimally invasive procedures, whether that be knee arthroscopy, hip arthroscopy, etc. And if and when that is no longer an option, we save a joint replacement as the last resort. So that's kind of a little insight on my particular perspective.
So with hip arthroscopy, talk to us about what's going on when you're doing a hip scope or hip arthroscopy. What are you trying to fix? What are you seeking to achieve?
So there's lots of things in the hip that can cause pain. Either a loss of cartilage, which is arthritis. Arthritis is nothing more than inflammatory disease that causes the loss of cartilage, okay? And once you lose that padding on the end of your bones, that bone rubs and that causes pain. That's one source of pain. Another source of pain is the labrum. The labrum is a piece of tissue that goes around the socket, okay? It's an extra piece of cartilage. Think of it like a car tire that goes around the rim of the acetabulum and helps hold that head into place. When that tears, that labrum is full of nerve endings. So it's very painful to get a labral tear. Mm-hmm. So patients that don't have arthritis, don't qualify or need a joint replacement, can qualify for a minimally invasive hip arthroscopy, where we make a couple small poke holes and go in with cameras and repair the labrum. So at that same time, you can remove bone, clean up cartilage, do things that you need to do to resolve their pain. So hip arthroscopy is a niche surgery. There's not a lot of surgeons that have received specific training in hip arthroscopy, and it's a particularly difficult surgery to perform well. Anyone can stick a scope into a hip, but not very many people can do a hip arthroscopy well and do it correctly and have good results.
Yeah, that's what I wanted to ask about good results. So you go into, and let's maybe not go to the extreme of trauma, where it's the worst you've ever seen, but you go into repair a labrum. Does that is that a permanent fix? Is it a 1-year fix, a 5-year fix, a 10-year fix? What do you typically see there?
So there's a lot of factors that determine that, whether it's depending on how long it lasts. Okay, so the important thing to understand about hip arthroscopy is the results are highly dependent upon how good the cartilage is.
Okay.
So if someone has poor cartilage or early arthritis, they're not as likely to do well with hip arthroscopy. But a patient that has good cartilage, they're a younger patient, and you do a labral repair, that should last them hopefully the rest of their life, we would anticipate, if not at least several years, get them out of the pain that they're having, get them back to the activities that they want to do.
Okay.
But
Well, so you know,
depends.
you made the comment about not everybody is trained or well trained to do hip arthroscopy, and I have this flash in my head to a Saturday morning in a hotel conference room, and there's 6 guys sitting around the table, and they're playing with a simulator, and they come out of there 2 days later, and the rep says, "Oh yeah, you're ready to go."
Yeah.
You know, versus what you went through. You know, maybe talk to our audience about just how much experience you have in hip arthroscopy, because I think it's one of the reasons I wanted you on the show is that you have an extensive amount of experience.
So I did a lot of hip arthroscopy in the military and had been doing it for years, and got a lot of experience because I was the only one doing hip arthroscopy at Fort Benning, and felt like I was pretty good. Okay. I felt like I had kind of mastered that skill and thought I was pretty good at it. And I was doing about 50 or so a year, which is a good number for hip arthroscopy, or so I thought. And it wasn't until I went to Duke University and shadowed a guy named Chad Mather who showed me how to do hip arthroscopy at a whole new level. And when I saw his skill level, I quickly realized there's a whole nother level of expertise in this and artistry in this particular procedure that I wasn't even aware of. And I had received specific training for hip arthroscopy through the military and had done hundreds of them. And yet when I went and saw him, I realized that's who I want to be. That's what I want to do.
I think it's interesting that he uses the term artistry.
Yeah, it's an art. It is an art, believe it or not. Takes a lot of practice and takes a lot of repetition.
Yeah.
Hip arthroscopy is not like a knee arthroscopy or a lot of these simpler procedures in orthopedics that we do lots of. It's a procedure that requires a lot of repetition, has a high failure rate if it's not done correctly. And I was fortunate to go back to fellowship and get to that level and learn how to make it even better.
Do you have an estimate about how many hip arthroscopies you've done now in your career at this point?
Yeah, well over 1,000. Just
wow.
Yeah, over the last few years.
You're a young guy too. I mean, you've only been in private practice for how many years?
This is my 3rd year out of the military, so
right.
my 8th year of practice. Yeah,
8th year of practice. I mean, that's on the spectrum of career scope. I mean, you could potentially do tens of thousands of these if that became if you decided that's what you wanted to do. But I mean, where does that rank in, and maybe you know this answer, maybe you don't, but where does that rank in North Texas or Texas relative to your peer group of having done well over 1,000 of these hip scopes? Does that put you in the top 1%? Is that, middle of the road?
It's probably, I'm guessing,
Yeah.
probably top 5% perhaps. And
is that more so because it's not for everybody, that it's really there's a specific set of conditions that a patient needs to meet to be able to be eligible for that procedure, and that's just not a big part of most orthopedic surgery practices.
Right, and there's not as many orthopedic surgeons that do that particular procedure. So you mentioned earlier, like, patients don't necessarily know what questions to ask.
Yeah.
One of the biggest, probably most important question to ask your surgeon is, how many of these have you done in the last year? Okay, key phrase. You don't want the guy who's done maybe a couple hundred, but the last one he did was 5 years ago.
Yeah. No kidding,
You want
right?
the guy who's been doing a couple hundred a year and did over 100 or so last year
Yeah.
of this particular
I wanna
procedure.
go
I mean,
Yeah.
that's such a great point, and that's no
Yeah.
different than anything. It doesn't matter what skill,
Right.
whether it's in business
Yeah.
or it's in sports.
Mhm.
I mean, CJ wouldn't want. Well, he doesn't really ever want me to be his golf partner. But if we're going to play competitive golf together, he's hoping I'm playing more than once a month.
Yeah.
I mean,
Yeah, I don't want to go see the golf pro that's given 5 lessons in the last year. I
Yeah.
want to go see the golf pro that's given 2,000 lessons
Yes.
in the last year.
100%.
Right?
Exactly.
And
That's a great point. Hopefully people are hearing that because
Yeah. And there's no shame
Mm-mm.
in walking into a physician's office and asking that question, and you
Mhm.
don't get the answer you're looking for.
Mhm.
And you're like, look, I would just like a referral to somebody that just has a little bit more expertise.
Mhm.
You don't have to tear the surgeon down, but I think there's a way as a patient to be able to say, I just prefer somebody with more experience. Who would you recommend?
Mhm.
And maybe the
Yeah.
physician gets pissed off and walks out and says, I'm not going to help you, but I don't think
Or
that's
ask for a
most,
second opinion.
Yeah.
Just say, I'd like to get a second
There you go.
opinion. You don't have to tell them. Just say,
yeah.
like to go get a second opinion and seek out somebody who has specific training in that particular surgery and has done a lot of them.
Yeah.
Yeah. No harm in looking for a second surgeon. You know what they say? If your surgeon says don't get a second opinion, that's
When you
when
should
you
get
need
a
to go
second opinion. Yeah. Well, that's interesting. I mean, now we're going to progress to the most invasive kind of end of the line treatment, which is joint replacement, hip
Mhm.
replacement.
Mhm.
Right? I think hip replacement has changed a lot
Yeah.
in the last 10 years, call
Okay.
it. Maybe talk to our audience about where things are at with hip replacement these days. What's the approach? Who does it benefit? We take people through that process.
So a more traditional approach to doing hip replacement would be the posterior or lateral approach.
Okay,
And
posterior being
posterior
back.
being
or-
in the back.
okay.
So this is how I was originally trained and did it for a number of years through the military. And it wasn't until I learned how to do the anterior approach I realized how much better it is. Now,
The anterior approach meaning through the front.
through the front,
Okay.
yes. So a few benefits and reasons why I transitioned years ago to the anterior approach from the posterior approach was one, when you do a posterior approach, you have to cut through muscle.
Okay.
Okay, anatomically, it's impossible to avoid cutting through muscle. You have to cut through the muscle, and you have to cut through tendons, release tendons, in order to get to the joint caps, in order to do a posterior approach, in order to do a hip replacement. The problem with that is it's a harder recovery. You're relying on the soft tissues to heal.
Mhm.
You have to repair those tendons and hope that they heal, and they don't always heal. And it's typically a larger incision. So the benefit to doing the anterior approach is I can make a smaller incision. I can go through an area that's easier for patients to see and treat and keep clean, as opposed to something in a more difficult region back in the back. But the biggest benefit to doing an anterior approach is the fact that I don't have to cut any muscle or tendon.
Muscle sparing.
It's completely muscle sparing. I can go in between the two muscles, push them aside, and have direct access with no tendons in my way, nothing else, and I'm able to do that directly. And this way, it's a faster recovery,
Mhm.
it's an easier recovery, and it's in my opinion a much better method. The biggest another benefit to it is the fact that you don't have precautions. When you do a posterior approach for hip replacement, you got to be more. Those patients are more prone to dislocation, more prone to having a limp or other issues. So in order to avoid that, for the first several weeks of your recovery, you have to be educated on what to avoid. Don't sit this way. Don't stand up this way. Don't do this. Don't do that. And keep a wedge between your knees while everything heals up. With an anterior approach, I don't have to do that. The patient doesn't have restrictions. I don't care how they sit. I don't care how they bend over or get up or whatever. That patients don't have to worry about that. And
Sounds
that's
a lot
a big
easier
I was
to
gonna say
do.
it's clearly the easiest
Yeah.
way to go.
Yeah,
so.
no kidding.
Well, so the counter argument is that the research that's currently out will show you, and it's only fair that I mention this, it's the research will show you that at 1 year, the outcomes are about the same. So
Okay.
here's my take on that research that other surgeons will refer to. If I were to sell you a car and say for the first year you can't go past 30 miles an hour, don't go through the mountains, don't do this, don't do that, and in 1 year that car will be as good as this car. Who's going to buy that car? Why do you want that car?
Yeah, exactly.
So who cares about the results at 1 year being close to equal?
Sounds like you're it's like getting on an airplane. Your flight was a lot less bumpy on the way there, you know? I mean,
Sure.
it's the same airplane, but
Yeah.
so do you really care if you get to the destination and you didn't have to go through agony on the way there?
Right. The initial recovery is a big difference. And I've seen that personally.
Sure.
Why doesn't everybody do the anterior approach? Well, that answer is simple. It's because
They
they're
don't
just
know how
not
to.
trained and they don't know how to do it. I have that unique perspective. Again, going back on my training, is that I saw how it's done in a posterior approach, and I made that transition. I see how much better it is. It's hard to go to a surgeon who only knows posterior approach and get their opinion and say, well, what do you think about anterior approach? What do you think they're going to say? Of course,
Right.
they're going to say posterior approach is just as good. Well,
So let's talk about robotics for a minute, right? Because we know
Yeah.
robotics has made huge inroads in a lot of other specialties.
Yep.
We know that robotics has been introduced in orthopedics. Does robotics play a role in joint replacement? And if so, what are the greatest benefits that you found? Or you maybe talk to us whether or not you use robotics, because we've interviewed somebody else that they really aren't a big fan of it.
so this is a hot topic, and what I can say is that even former presidents of the American Hip and Knee Society have stood up at the pulpit and said the future of joint replacements is in robotics. So those peers of ours that we look up to that have done this for several years themselves are proclaiming that the future is in robotics, and I totally agree with that. So that's another transition I made over the last few years, was into robotics. So I did total knee replacements, just using the standard techniques, and then I slowly got into robotics, seeing the benefit of it. And the more I started doing robotics, the more I saw how much better the ultimate results can be. So I have a lot of experience in robotics, particularly in the knee. I think that's where, so far, the biggest benefit has been. And they are just now started getting into robotics with hip replacements. And there are some clear benefits to doing that.
So when you're talking about there being benefits and it seems to be a superior option, is it because of how you're cutting bone, or is it the machine cutting the bone, or is it tell me cut here, not here? Is it the actual placement of the implant? I mean, what role does robotics play in joint replacement at this point?
So the huge benefit to robotics is the precision. And let's take a knee replacement, for example, since that is where it's made the most progress so far. It's yet to come in advancement of hips, and we're just kind of getting there with hip replacements. But for a total knee replacement, and this may be a shock, but this is true data has demonstrated that total knee replacement outcomes only have 80% good to excellent outcomes, meaning that 20% of patients that have a perfectly done knee by the best surgeon in the country is not satisfied. 20% of a total knee replacement, those patients in a perfectly done knee are not happy. So only an 80% success rate is not that good, especially when you compare it to a hip replacement. Hip replacements in the upper 90s, probably anywhere between, depending on the literature, you read 96 and 98% success rate with hip replacements. Okay, so we are not there yet with knee replacements. And one of the reasons we believe is because of the accuracy of the procedure itself. Every knee is so different, just like every patient is so different. And the trick to a good total knee replacement is balancing the ligaments. Those ligaments around the knee we maintain, we keep those. So all we're replacing is the cartilage and replacing it with metal. But if those ligaments aren't perfectly balanced because your cut is off 2 or 3 degrees, you're going to have a loose knee. You're not going to be happy with it. So that's where a huge benefit comes into play through robotics. It's more precise, it's far more accurate, and you can tailor that joint replacement to that patient. You see, the standard way of doing knee replacement is you'll throw a jig. We call a jig, or a measuring guide, okay? So you're gonna take that measuring guide and you're gonna put it on there, and you're gonna look at it and you're gonna say, that's 5 degrees right there. Okay, nail it in place, make your cuts, it's about 5 degrees. And then you're gonna put your implants in, and then you're gonna look at the knee and you're gonna balance it and say, oh wow, it's really loose on this side. Okay, well, I'll just adjust this and I'll cut this ligament to stretch it out, and then, okay, now it's even. Well, the benefit to doing it robotically is that you can know exactly how and where to put that implant, at what precise degree, and know exactly how much bone to remove before you even do it. So the robot can tell you that and give you that information. And then when you're doing it, now, for those that aren't familiar with robotics in joint replacements, I'm still doing the surgery, but it's a robot that's doing the measurements and making the calculations and making sure that all my cuts are precise to 0.1 millimeters. So the degrees and the precision is so far more accurate than what we can see with our own human eyes. That's the benefit. I can put the implant where I want and know that it's perfectly placed before I even make a cut.
So how many robotic surgeries have you done?
Hundreds.
Yeah.
Yeah, been doing it. I do all my knee replacements robotically. I have done for the last 3 years, and then with I do some hip replacements robotically, just depending on the particular patient and the indication. Some patients need that additional measurements to be more precise, and others were able to get just as precise and accurate without the robotics. So
interesting.
Yeah.
You know, this has been a hell of an education. In
Maybe the best we've had so far.
It's
really good.
Pretty darn good, right? I mean, now I understand why there's 9 years of, post undergraduate education plus, I mean, 9, 10, 11, 12, however many years it is.
yeah.
To get to a point where you can basically say, hey, I can do this on my own. I mean, that, and then you're a freshie and you got to build from there. But I mean, this has been awesome. Like I didn't really understand, and I can only speak for myself, but I didn't understand just how valuable a tool hip arthroscopy could be, and the fact that it could really help me avoid a total joint replacement. And obviously, the precision part of robotics. I mean, it's kind of hard not to ask for it now that we know what the benefits are. Yeah. Right.
Well, it's interesting because one of our previous guests, and it's been several weeks back, actually was discussing the same thing with a jig. And I thought to myself the whole time, I said, this is it almost feels archaic.
Yeah.
Like it's almost like, back in the day where you put your protractor on a piece of paper and like draw a circle. I mean, okay, it's accurate, but how accurate is it? Know? And that's just huge what we're able to do now using technology and robotics.
It's really cool. So Dr. Evanson, for our audience, how can they find you?
I'm at Plano Orthopedics, and I can also be found. I have an Instagram page called The Hip Doc. Okay. So I got a lot of fun videos on there you can look at just for educational purposes. You can see a lot of the videos that I posted from actual surgeries that I'm doing. So you can see what a hip replacement looks like. You can see what hip arthroscopy looks like, what a labrum actually looks like. And you can reach me there. I'm on, I have my own website, drrichardevanson.com. And then you can also find me on posmic.com, which is Plano Orthopedic Surgery, Sports and Medicine Center, posmic.com. So you can find me on either one of those.
For those that don't know, Plano Orthopedic, top-notch spot. I know growing up as the youngest of 4 brothers, we've all made a stop there at one point, but a really wonderful. How many docs at Plano Orthopedics?
So we are now 13 strong, and we're about to add 2 more.
Terrific.
Yep. So there'll be 15 of us.
Great spot. If you want to go get a first or second opinion, that'd be a great spot to go.
Parting thought for any patients who are sitting on the fence going, Yeah, maybe I should go see somebody after listening to this.
Well, the big benefit to plain orthopedics is we have a specialist for each particular body part. So you don't have a shoulder surgeon doing hip replacement.
Mm-hmm.
You don't have a surgeon doing a hand surgery 1 minute and then a foot and ankle surgery next minute. They are experts in their particular field, and that's what drew me to this group. Is I could focus on hip. I also do knee replacements because I love doing knee replacements, always have, and that's the kind of place you want to go to, where you can find somebody that is expert training and that is focused in that particular field. So
Terrific.
yeah.
Well, awesome, man. Well, this has been a lot of fun. I mean, our
So
time's
fun.
flown by.
Thanks.
Really enjoyed
Appreciate you guys
having you.
me.
Yeah.
And man, we look forward to getting this up on the World Wide Web and all of our different social media spots and being able to share the heck out of this, because this is great information. I mean, it's such a unique perspective to have somebody who is so specifically trained in an area of the body that everybody and their brother feels pain.
Yeah.
Right. So now it's time to get that information out there.
For sure.
Well, till next week, we appreciate everybody who's joined us. I think that we actually have a very interesting guest next week that is it's a brand new FDA approved implant to help regrow cartilage, I believe, is our guest next week. So it'll be interesting to unpack that and how that all came apart, or how that all came about, and be able to go from there. So follow us on Instagram, Facebook, YouTube, Spotify, Apple Podcasts. Find us. I guarantee you will not regret it. Till next week, y'all have a good one.